right, so we are back with the fabulous Dr. Anor, who's just come back from safari in the wards and had lots of fabulous flourishes in our video. She's now going to deconstruct each component step by step. So over to you.
Great. So first of all, remember before you do anything, number one, have you introduced yourself to your patient, which is what I did. Second thing, have you explained what you're going to do to the patient? So explain that you're going to palpate her abdomen, you're going to do an internal exam with your fingers, as well as insert a speculum in order to see her cervix and do a smear of her cervix. None of this examination should be painful if she doesn't already have a lesion that is causing pain by itself, but all of this should be explained to her. Definitely it can be uncomfortable, but you also need to explain this to the patient and reassure the patient. So what you need for this examination are a pair of gloves. These need to be non-sterile gloves. It's only in obstetrics where you're doing a speculum for someone who has ruptured membranes where you would need sterile gloves. But in gynae, non-sterile gloves should be fine for a speculum examination. Then we need our lubrication. Please make sure you find it and line it up long before the patient is naked on the bed, because you don't want to be running around looking for lube in our hospital if you can't find it. You need a speculum, and please make sure the speculum is appropriate to your patient's size. You have speculums that vary in size from very large to very small. This is a medium-sized Cusco speculum, and it suits most middle-aged females. However, if you have a teenager who's maybe only had one sexual partner, or if you have a multiparous 50-year-old woman who's had 7 vaginal deliveries, you might need a larger speculum. Remember, you're never going to be doing a speculum examination on someone who is a Virgo intacto. Then you need your devices that you're going to take your smear with. We have 2 over here. We have a wooden speculum, a wooden spatula, and this wooden spatula should be enough to get an endocervical component from most cervixes. This is the little bit that goes into your cervix. However, some people have cervixes that have a very, very tight stenotic external os, in which case you might need an endocervical brush to squeeze through to get some cells. If you have both, it's always helpful to take a smear with both of them. Then you need a slide, again, which is pre-prepared. Dr. Gordon, my assistant, has wonderfully written the patient's initial and surname. Remember to also follow with the patient's folder number, depending on where you're working. This should be done before the patient is undressed and on your table, because it is something that does take quite a bit of time. You need a bit of tissue so that the patient can wipe herself off after the procedure. You need some cytofixative spray, and make sure there's enough in it, and you need your patient. Okay. So to start off with, as I mentioned, I've already introduced, I've already explained, and I've already got consent for this procedure. I'm going to start with an abdominal palpation. Using my flat hand, obviously, if she has told me she has pelvic pain, I would start away from the pelvis and move towards it. This patient in our example hasn't told me about any pain. I'm going to start with a light, general palpation. The direction is not important, but cover all of your abdominal regions. Then we're going to follow with a deeper palpation. You can as well add in blotting kidneys as you would in internal medicine, but that's not a major focus for us in gynae. After my deep palpation of the abdomen, we're now going to move on to the genital examination. So we move our cloth that's covering the patient up. We uncover her genitals, but we make sure the top of the patient is covered. To start off the examination, we're going to first do our speculum and follow up with our bimanual examination. So we put on our gloves. We always would like to warm up our speculum. We can do this by squeezing the speculum in our hands for some time. Once that's done, we're going to grab our lubrication jelly and apply some lubrication along the edge of the speculum. Make sure not to put it right at the tip, because that's going to obscure our view, but we definitely want it where the speculum sort of rounds off and starts to cause friction in the vagina. So once that's done, we make sure that the speculum is properly constructed. This little bit is through the the hole and ready to be launched if we need it to be launched. Launched is not the right word. And we then begin our speculum examination. We always start with inspection of the external genitalia. We look at the labia majora, labia minora. We look at the clitoral hood as well as the perianal area, and she has no lesions that we can see. We then spread our labia minora and majora by pushing on the labia majora, and then we should be able to see a slight gape in the introitus, and again we look for any obvious lesions such as warts, etc. that we can see. We take our lubricated speculum and we rest it gently against her posterior fourchette. At this point, and just before we do this, we actually warn the patient that the speculum might be cold and she might feel it. We also ask her to gently bear down. When she bears down, we will see that her introitus gapes a bit, and I then use that moment to gently advance my speculum in a posterior direction, inserting it at a 12 o'clock position or 3 o'clock position and swiveling up to a 12 o'clock position, making sure not to clash with her clitoral hood and cause her any discomfort anteriorly. Once we've inserted fully, we can open our blades up and visualize our cervix. Once we can see our cervix, we're squeezing these two blades together. We screw this guy into place and keeps the blades open. So in our example, this is what you can now see at the end. Obviously, leading up to this, you'll see the vaginal walls. We inspect the vaginal walls. We're looking for discharge. We're looking for lesions. And right at the end, we see our cervix. Again, with our cervix, we're looking for discharge. We're looking for lesions. We're looking for inflammation. And our inspection is now done. In terms of our pap smear, we grab our wooden spatula. The little knob that's the highest point goes into the endocervix, and you do a 360-degree swivel of the entire cervix. You remove the spatula and you take your slide and you wipe all of the residue that you have collected. If you only have one spatula, you can use your entire slide, but I just want to show you how we would use the brush. Again, if your cervix looks like this, it's not necessary to use the brush, but in a patient that has a very tight os that spatula cannot get in, the brush is ideal to go right into the endocervical os, remembering we want to sample the transformation zone, which might be quite drawn into the endocervical canal in some patients. Once we have a sample with our brush, we swipe the brush again against the slide, and once we have swiped, we grab our cytofixative spray, always shake it first, aim about 30 centimeters away from your slide and spray. It should be wet enough to see it looking wet just before it starts to drip, and place your slide somewhere safely. Then in terms of our patient, we are going to slightly clip together the two blades, remove our screw, ask the patient to bear down, again to relax her pelvic floor muscles, and gently remove the speculum. It will be easier than this in real life.
Way easier than this in real life.
We don't
Let me give you a hand. We have no lubrication on this, guys.
And as the speculum blades start to move, you allow them to gently close. You twist back to your 3 o'clock position and exit. Please don't forget to twist. Never remove the speculum in this position. You're gently moving off, twisting, 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 and allowing the blades to close. Now we've done our speculum examination. What follows next, cut that out. Now that we've done our speculum examination, what follows next is our bimanual examination. Grab a bit more of your lubricating jelly and apply it to your 2 fingers, your index and your middle finger. Apply the examining or palpating hand to the abdomen. Rest your fingers at the patient's introitus. Again, ask her to bear down and you'll see the introitus bulge open slightly. Advance your fingers slowly until you meet the cervix. Once you have reached the cervix, use your palpating hand to deeply palpate in the suprapubic region, and with your examining hand that's in the vagina, push up on the cervix. Once you've done that, you can literally feel the uterine fundus, and at the bottom you can feel the cervix, and you can approximate the distance between your two hands. And with this patient, I can feel that this uterus is about 12 weeks size. Once we've done the suprapubic component, we move across into the adnexa. I'll start with the right actually. So your examining or palpating hand goes deep into the right iliac fossa. Your vaginal hand swivels across into the right adnexa, and you're trying to see if your hands can kind of approximate each other, or if there's a bulge between your fingers, or if there's tenderness elicited when you're doing this examination. Similarly, with the middle component, we're checking for cervical excitation tenderness and tenderness on the uterine fundus. And the last bit, we move across to the left iliac fossa, we deeply palpate. Our left fingers move across into the left adnexa, and we see if we can approximate our hands, if there's a mass in between our fingers, and if there's any tenderness. Once we're completing the procedure, we remove our fingers from the vaginal canal, dispose of our gloves in a sterile manner. We give the patient a tissue to wipe herself off. Don't forget this part because we've left a whole lot of gel on her. And we allow her to hop off the bed, go and change. When she returns, we'll explain our findings and explain exactly what we're going to do with the specimens obtained.
Great, thank you very much, and stop.